I am Anna Lucre. I co-direct Peds Echo Hawaii, and I will be here to help facilitate Dr. Beaty's session. Any questions, feel free to put in the chat, and I will pass them along or hold them till the end, depending on what our flow is doing. And you can, of course, always unmute yourself and feel free to speak into the group. And yeah, without further ado, I will pass it on. Thank you all so much.
Okay, and my name's Dr. Beaty. I'm one of the pediatric pulmonologists here at HPH and a JABSOM clinical assistant professor. I'm gonna go ahead and share the screen. As was stated, I have no disclosures, and I have no specialized training in scoliosis or pulmonary effects of scoliosis other than being a clinician and taking care of many of these patients and seeing the benefits and pitfalls. And this is something that we will commonly see among any pediatric clinic. And there are some misperceptions out there about what the benefits of the surgery are going to be as far as your pulmonary function. So that's the primary goal of this topic. Are we good? Can everybody see the screen? Okay. And my sound level's okay? All right. So pulmonary puzzles, actually what you guys are seeing are my first attempt at ChatGPT. I asked it to give me a humorous title for this talk, and it was way too humorous. So but I took the word puzzles out. So I'm gonna start off with the case report. This is a patient that we take care of here at HPH. He came to us as a 14-year-old male with chronic disease as a result of his premature birth at 30 weeks gestational age. He suffered from an IVH and had hemorrhagic hydrocephalus, received a VP shunt, and resultant cerebral palsy, global developmental delay, epilepsy, and dysphagia. He had a G-tube and Nissen, and he was diagnosed with neuromuscular scoliosis that was first detected when he was 8 years of age. Spinal X-ray measured his Cobb angle of 70 degrees, but his deformity was considered more significant than that due to significant kyphosis as well as rotation of the spinal column. And we'll talk about what all of that means. These are his films prior to his scoliosis repair. So you can see on the left, his thoracic curvature is present, but not all that significant. But has this significant curvature of his lumbar spine and kyphosis as well. These are his x-rays after a posterior spinal fusion. And so what you'll notice is that there's still some residual lumbar curvature. His thoracic spine is fairly straight, but it had started off straight. But now what we see in his x-ray is his trachea is perhaps off midline, off to the right, and he has much more visible lung tissue in the left hemithorax compared to the right hemithorax. There may be shifting of the heart over to the right as well, and elevation of his diaphragm on the right side. And this is actually when pulmonology got involved. We will catch up back on that story later. So first of all, do you have to have some understanding of what normal is before talking about what abnormal is? So as we all recall, the structure of the thorax is quite complicated with 12 ribs, which each have attachments to the vertebrae in the back. The first 6 or 7 ribs have a single attachment, which is cartilaginous to the sternum in the front, and then we have some shared cartilage joints from the lower ribs onto the sternum. Each of these ribs have accessory muscles of respiration in between, but the internal and external intercostal muscles, which assist in respiration. The primary breathing muscle is actually the diaphragm. These solid arrows represent a active movement, and the dotted arrows represent passive movement as we're breathing. So respiration would involve lowering of the diaphragm, possibly some expansion of the chest wall to create a negative pressure, which is the driving force for air to come in. Quiet exhalation is passive, relaxation of the diaphragms to raise those up. It is possible to have an active expiration with contracture of the abdominal muscles to create a positive pressure in the abdomen to create a greater driving force to the lungs and the expiration. Here's a representation of the joint between the ribs and the spine in the back. And this is the bucket handle inspiration. As you take an inspiration, the ribs lift and rotate outwards, and then actively, and then fall back down passively. Briefly going to review the lung volumes because we'll be talking about this. The primary volumes we'll talk about are the tidal volume here. So this is the volumes inside of our lung as we're passively inhaling and exhaling. At the end of a normal tidal volume, this is called your functional residual capacity, which I'll explain in a minute. A very important value. And then if you think about a maximal inhalation and a maximal exhalation, this is called your vital lung capacity. So this is essentially, if you were to have maximal ventilation, this is your area where you can do that. Notice that a tidal volume is much less actual volume than your vital capacity under normal circumstances. Just briefly recall, with a normal chest wall, the chest wall is compliant, has a tendency to expand, and the lungs are elastic and have a tendency to collapse. Your individual FRC is determined by where the forces of the chest wall expanding and the lung collapsing are exactly counteracted. So this is your FRC is a natural resting point of the interplay between your lung and your chest wall, which is represented in this picture here. So these are normal values with percent of your vital capacity on the x-axis over here, sorry, y-axis over here, and total lung capacity on the y-axis on the right side. So this person's FRC, determined by the chest wall and lung interplay, is right at about 48% of his total lung capacity, or about 38% of his vital capacity. What I'm trying to get at with this slide is that if you change the compliance of the chest wall, you will change this patient's FRC. The natural resting point will shift. So scoliosis. This is obviously a heterogeneous disease. Most of the cases you're going to see in your clinic are actually idiopathic, about 85% of all cases. The incidence of idiopathic scoliosis ranges between 0.3 to 15% of the population based on your population and how scoliosis is actually defined. But about 5 to 10%. It's going to be more common in adolescent females in a ratio of 3 to 1. There is a genetic component. It's considered a single gene disease, but with variable expression. If a child has 2 parents with scoliosis, they actually have a 50 times increased risk of developing scoliosis. The cases I'm involved with are going to be primarily neuromuscular, congenital, or syndromic scoliosis. Syndromic just means this is a patient with scoliosis due to an underlying syndrome such as Marfan. You would categorize any kind of scoliosis based on their age of development. Can be congenital, born with it. This is typically due to a vertebral malformation. Early development within the first 10 years of life, or adolescence development as a teenager. You would define scoliosis based on its location. Is this thoracic? Is this lumbar? And there are many, many ways that have been developed to try to measure severity, but the most common is called the Cobb angle. How you measure the Cobb angle is you take the upper intervertebral disc of the most angled vertebrae and the lower vertebral disc of the bottom most angled vertebrae, extend the lines between those and measure that angle. Some scoliosis, because this is a heterogeneous disease, is going to be highly likely to progress. Some scoliosis is going to be highly unlikely to progress. The most likely to progress is infantile scoliosis. These children tend to have vertebral anomalies, and as the vertebrae in the spinal column continues to grow, that deviation is going to continue to worsen and worsen without treatment. Sometimes it's been reported to spontaneous regress. And this is considered more on the rare side rather than the 60% side. With a small Cobb angle, less than 25 degrees, these patients are actually at low risk to progress as they go through their adolescent growth spurt. You can see this in the top row of pictures here. This is a patient with mild scoliosis of about 12 degrees, which progressed to 22 degrees at 8 years of life. By the time they were 10 years of age, without treatment, it had actually regressed back down to 11 degrees. So a small Cobb angle is much less likely to continue to worsen. A Cobb angle greater than 40 degrees, on the other hand, is significantly more likely to progress. So these are images of a child who actually got lost to follow-up between a couple of times, between 9 years and 11 years, and then again at 14 years of age. And you can see this patient, similar degree of scoliosis here, but as he continued to progress above 40 degrees, by the time that patient was 14 years of age, that scoliosis had worsened significantly. Also, for all of us, our chest wall compliance decreases with age due to improved musculature, stiffening of the joints between the ribs and the vertebrae and the sternum. This is accelerated in people with scoliosis because those joints get stretched and compressed, and the musculature between the ribs actually get compressed as well, which I'll show you in a minute. You get loss of spinal flexibility as the scoliosis progresses, and this leads to progressive increased work of breathing with particularly with exercise, which may actually be the first symptom that a child with scoliosis complains of. Exertional dyspnea based on decreased ventilatory capacity. This displacement and rotation, which is important, of the vertebrae leads to asymmetric lungs. You're going to have one lung which is just convex and larger, and the other lung which is concave and smaller. And we know from 4D CT scans, where they look at the CT scan over time and the volume of the lung itself, that this leads to asymmetric inflation of the two lungs, with the convex lung getting the majority of the ventilation and the concave lung getting much less. You get changes in the AP and transverse diameters of the thorax. So children with scoliosis tend to have more of a funnel chest up top. Ribs may flare, or particularly on one side with the scoliosis at the lower rib cage. You tend to have a smaller AP diameter where the sternum is not as far out from the spine as would be, but almost like a pectus, the sternum gets pushed in often. This is a complex three-dimensional structure, which includes rotational forces. I'll have some images of this. And this is one of the main things that the Cobb angle misses out on, because the Cobb is a 2D measurement of the curve of the spine, but doesn't assess at all rotation of the spine. If you think about the muscles in between these ribs, you're going to have intercostal muscles on one hemithorax, which are over distended, muscle fibers stretched out, maybe unable to generate the forces that they need to. And then on the other side, they're compressed and they're going to be unable to expand. And in some cases, the ribs actually fuse together and you have complete loss of the muscles there. Just like any other muscle, as these muscles have been distorted, they will atrophy or fibrose over time. And then you have essentially permanent loss of the musculature. This also involves changes of the diaphragm. So as you have one lung compressed, you will lift the diaphragm on that side. Those muscle fibers are going to be compressed, not able to function as well, decreased excursion. You'll also have an overdistension of the diaphragm on the other side, which leads to, again, atrophy and fibrosis of that diaphragm, which may be permanent. Infants with early onset scoliosis commonly present with short expiratory pushes using their abdominal musculature. What this means is that their normal ventilation or their baseline ventilation is active. They're using their abdominal musculatures to push out the air because of their scoliosis that occurs in infancy. This also changes how the lung develops. So children born with early onset scoliosis have decreased alveolarization, decreased numbers of alveoli in the compressed lung. This does affect children with scoliosis that develops later in life, because we know that they have a normal number of alveoli if the scoliosis has occurred after 7 to 8 years of age. But the size of the alveoli by the time they're an adolescent is reduced in the concave side. Most children now are actually treated for their scoliosis. There is a study, though, from Japan with autopsies of elderly people who had untreated scoliosis. And what they found is that in 80-year-olds, for instance, with untreated scoliosis, they actually have complete loss of alveoli in the upper lobes of the compressed lung and decreased alveolarization of the lower lobes. But then on the right side, they saw overdistension and inflammation of the alveoli on the convex side. In all patients with scoliosis, there's a reduced vital capacity. So the volume of air from a maximal inspiration to a maximal expiration is going to be reduced because of that decreased chest wall compliance. And this is most pronounced in the earlier the onset of the scoliosis. So this is an example of a Cobb angle, which is significant. This is a 110-degree angle. But again, the Cobb angle, 2D measurement, there's no analysis of the Cobb angle to compensate for this child's kyphosis. Similarly, this is a CT scan showing the rotational forces of this patient with scoliosis. And you can see in this patient, even after repair, The child's spine is likely straightened some, but there's been no real significant difference in the child's rotational forces. So all of these joints are going to continue to be either restricted or overdistended. So briefly, yes.
Oh, I'm so sorry to interrupt. I was just saying there was one quick question there. If there were, I don't know if it was for this slide or the one before, but overall the question was if there were more alveoli in the non-compressed lung.
Alveoli in the non-compressed lung. I do not believe so. That's not what was seen. But the alveolarization occurs from before birth, right? But the majority is going to occur from birth to 8 years of age. And so once you've reached that, you're not going to develop more alveoli, even though the lung is stretched. So what's seen in those autopsy studies was that you have a normal number of alveoli, but they've been stretched out and distorted. They reported increased inflammation, which is typically going to be neutrophilic inflammation in the alveolar walls. We don't know why that happened, but the likely thing is the overdistension of the alveoli has led to release of cytokines and increased inflammation in those normal number of alveoli, but they've been stretched and overdistended. Good question. All of those things obviously would also decrease the ability for those alveoli to function with oxygenation. So if you have decreased number of alveoli in one lung, you're going to have decreased oxygen diffusion from the alveoli to that bloodstream. But then if you have a normal number of alveoli here, but they're overdistended, then and inflamed, the edema that occurs in the alveolar walls also impairs diffusion. This is real briefly just a description of restrictive lung disease, which can occur in scoliosis. If you have a normal lung volumes on this side, with restrictive lung disease, your tidal volumes are going to be lower. They're also going to be at an overall lower lung volume. So this patient's FRC is lower than this person's FRC. The total lung capacity and vital capacity are lower as well. So what do we do about lung function and scoliosis? This is actually a very difficult question to answer. There's lots of different reasons for this. I've listed a few here. So the primary way that we measure lung function is through spirometry, plethysmography, and diffusion testing, DLCO. To perform any of those tests, patient has to be cognizant. They have to be physically and mentally able to follow the directions and maneuvers that you are asking them to do. And they're not easy maneuvers. They can be quite uncomfortable. And so if we are looking at scoliosis repairs among young patients, often it's going to be impossible to do traditional lung function testing in those patients. Lung function increases as we increase in height. And a lot of that is because of expansion of the chest wall and growth of the vertebrae. So if you're looking at a disease process that affects the patient's height, it's going to affect the lung function results that you're getting anyway. So we correct lung functions for height, but if that height is abnormal because of the actual disease that you're testing, how is that going to affect pulmonary function? There are studies in young children. I'll go over one of them later. For children less than 6 years of age who cannot do traditional lung function testing. These patients, actually very interesting, they were anesthetized and actually had lung function testing mechanically while they were intubated and having a ventilator breathe for them. This tests the good test of vital capacity that the machine can do for you. What happens basically is you get a pneumatic device that compresses the chest wall forcefully to simulate a forced expiratory effort. Unfortunately, because the patient is not using their own musculature to do that, they may not be truly reflective of what the patient could actually do on their own. And there's all of these tests, trials that do this are typically one intervention, and all the patients in that study get the intervention. It's considered unethical now to have a child with severe scoliosis who needs surgery and watch their natural history while you offer another patient a therapy. So none of these trials are going to have controls. And there's going to be very few trials that actually compare surgical techniques as well. To get over some of the issues with lung function data, there have been other ways to measure lung function over time, like a 4D CT, looking at that ventilation over time, MRIs, measures of compliance of the lungs, but none of these have really been extremely well studied, and we don't tend to use those in a clinical setting. They're more in the research setting. There are functional tests here, or tests of overall health, like weight gain, as I've listed, are sometimes used as surrogates for improved lung function. So this study is a comparison at a single point of time, looking at how does lung function correlate with worsening Cobb scores or kyphosis. And so if you look at the bar graphs on the right, you'll see that lung function decline compared to Cobb score is non-linear. So these patients actually have preserved lung function up until a Cobb score of 40, and only moderate or severe impairment starts increasing basically at about 60 degrees of Cobb, and then worsens significantly once the Cobb angle gets to 80. So the lungs can actually tolerate quite a bit of angulation before you're losing a large amount of lung function. Kyphosis is actually well preserved for quite a severe degree of kyphosis. However, there's a wide spread here. So if you look at this individual who has a Cobb score, a Cobb value of looks like about 60 degrees, this patient's lung function was measured at excellent, superhuman, higher than 120% predicted. Whereas this patient with a similar Cobb score, maybe about, between 60 and 70, his FEV1 is severely reduced, less than 40%. There's a high variability in how does the Cobb angle relate to lung function. A large portion of this likely is due to the things we've talked about: rotational forces, the degree of combination of Cobb angle and kyphosis. So this is a really highly variable measurement. This is the study that I had mentioned before, the young children who had undergone vector surgeries and had their lung functions measured passively while anesthetized. The mean age of the children in the study was only 4.8 years of age, and they were followed for at least 6 years. So their last follow-up was 6 years after the initial surgery. So what you can see is that these children started with severe scoliosis. Their initial Cobb angle was 80 degrees. And there was improvement that persisted till their last follow-up, still at 67 degrees. Their kyphosis at follow-up had actually worsened, however, because there was no correction of the kyphosis during the surgery. They followed their forced vital capacity. So this is how much air from total inflation to total exhalation, but passively with that pneumatic device. And over that 5 years, as measured in liters, they did show that the children increased their forced vital capacity, and it was statistically significant. This would be expected, however, as we mentioned, as you grow in height, your vital capacity should increase. That's why we correct for percent predicted. So if you look at their child's FVC as a percent predicted compared to their height, they actually lost FVC. So they're growing their FVC as they grow in age and size, but they're not keeping up with the expected level of growth. So their percent predicted has declined through those 5 years. This is a measurement of the children's lung compliance over those years. And similarly, they had a drop in their lung compliance over the 5 years, presumably because of scarring from the surgery and changes in the vertebral growth in height and stiffness because of the surgery. So when patients come to us, what we actually tell the patients as far as their lung function is that what you're going to see is that whatever your child's lung function is now, are you off of oxygen, no desaturations at night, are you able to ambulate? Immediately after the surgery, for the first couple of weeks, you actually see a reduction in their vital capacity by about 40%, which is significant, as they heal and recover. This leads to, possibly desaturations postoperatively, need for positive pressure ventilation postoperatively. As they recover from the surgery, you do see their lung function improve back. The vital capacity will improve back. But what tends to happen is you get back to the lung function you had prior to the surgery. So your benefit of the surgery is not to improve your lung function over time. What you do see is that as you measure those patients' lung function moving forward, what you've done is prevent further decline that would have occurred if the scoliosis continued to progress. So you're basically freezing that lung function in time. Because of that large drop in vital capacity after the surgery, if a child is already on the edge, these are children who they get a cold, they're at least on oxygen, if not on BiPAP or intubated. They're on that edge between respiratory failure or not. A drop in vital capacity of 40% will put them into respiratory failure. We see this pretty commonly, actually. They are going to have, as a result of the surgery, increased atelectasis. They're going to tend to not take deep breaths. They'll be splinting because of the pain of the surgery, and they're going to suppress their own coughs because it hurts to cough. So these children often get mucus plugging, decreased airway clearance. Because of this, we work closely with the orthopedic surgeons now about, we actually meet every month planning for surgeries on patients with neuromuscular scoliosis. How are we going to improve this patient's airway clearance perioperatively and as they recover? And often there are other lung issues itself, but due to the massive fluid shifts as they lose large amounts of blood in the surgery and then are replaced with fluids and blood products, frequent pleural effusions and edema. So back to our case, the 14-year-old who had not been able to wean off of BiPAP postoperatively, although he was stable on room air preoperatively. He had straightening of his spine, but elevation of his right hemidiaphragm, possibly deviation of the trachea to the right. Pulmonology was consulted due to the inability to wean him off of the BiPAP. And he had already received 2 weeks of antibiotics for suspected pneumonia. A bronchoscopy was performed, which showed copious airway secretions, primarily on the right, with mucus plugging. The secretions had stayed in the airway. They had gotten inspissated, dehydrated, so they're thick and sticky and impossible to cough or suction out. We recommended a fluoroscopy of his right hemidiaphragm, which suggested there was mild paradoxical movements, meaning as the patient tried to inhale, rather than the diaphragm going down, it was rising. So this diaphragm likely has been fibrosed due to being compressed for so long. With recurrent bronchoscopies with therapeutic aspirations, removing those plugs primarily from the right lung, we were eventually able to get him extubated, but he actually had a new pulmonary baseline of nocturnal CPAP without oxygen, whereas he had been fine without CPAP prior to that. His total duration of the hospitalization post-surgically was 4 months. Have an image of his initial bronchoscopy on the left with those thick secretions, which are primarily in the right main stem and a little bit down into the left. And after we had cleared out all of his secretions, this is his x-ray, which still showed some elevation of the right hemidiaphragm, but continued deviation of the trachea over to the right. You can now see mostly the right main stem here. So improved, but not cured yet. As this patient continues to recover, you would expect him to get closer to his baseline lung function, but he's likely, and it's possible he may get off of CPAP in the future, but it's unlikely that as far as his lung function, the scoliosis is going to, in scoliosis repair is going to have any significant improvements in that. And that was my whole presentation.
Thank you, Dr. Beaty. Anna has some question, one more question in the chat, and I will launch the poll while she does that one.
Yes, that sounds perfect. And there are other questions popping up in the chat as well. Shall I let people maybe briefly use their brains to focus on the exam? Since we have time, we can actually go over post-test questions and individually go over post-presentation questions. These are hard questions. This is definitely the last little brain teaser before everyone can go into their afternoons today.
I apologize, I didn't go over question 4 in the lecture.
Well, we'll see how well people can guesstimate based off of everything we did talk about.
Everyone guessed the same, so I'm guessing everyone's doing well.
Yeah, they guessed accurately on that one.
So we are about more than halfway. I'll leave it up for another minute or so.
Okay. Summer is very good about keeping us, holding us accountable for getting through our questions in a timely manner.
Okay, and I will end the poll and we can do chat questions and poll questions.
I don't know if you have an order of preference.
Well, yeah, why don't we do the post-session questions? I haven't looked at the chat, but I have this up.
Sounds
So
good.
the first question was scoliosis affects the respiratory system by, and the correct answer is all of the above. You have decreased chest wall compliance. Remember, you have over distension of the muscle fibers on the convex side and under distension of the muscle fibers on the concave side. And then you also have decreased alveolarization. I guess I should have put generally with early onset scoliosis, but what I intended was for all of these above, all of the above. These are changes that happen in the respiratory system in response to scoliosis. In regards to the Cobb angle, the correct answer is actually that Cobb angles greater than 40 degrees are likely to continue to progress. So recall that lung function decline is actually not seen until the Cobb angle is very, very severe. You have relatively preserved lung function until you have Cobb angles 60 degrees or higher. And then at the 80 degrees, you had a significant increase in lung function impairment. Cobb angles do not accurately reflect rotational changes on the chest wall. The Cobb angle is simply a two-dimensional measurement of the curvature of the spine. And the primary goal of scoliosis repair, I did not say this explicitly, I meant to imply that the goal of scoliosis repair is to halt further lung function declines, because if you allow that scoliosis to progress, lung function decline will also continue to progress. And the other thing are improvements in other areas of life. Can you improve pain, posture? I frequently have parents of patients tell me their eating is better now because I can sit them up and they're not slumped and trying to eat at an angle with food pouring out their mouth, choking on their food as they're swallowing, things like this. In regards to pulmonary function, scoliosis repair does reduce vital capacity by about 40% perioperatively. This is the reason why children following their scoliosis repair may not be able to be extubated or weaned off positive pressure ventilation for days, weeks, and in the case of my patient I presented, at least several months at this point. It does not invariably improve FVC as percent predicted at 2 years of follow-up. Remember, there was improvement in those vector study actually of improvement in FVC by liters, but they did not keep up with what would be predicted for a normal child their age. And so the percent predicted actually dropped. And lung function is not easily measured in children with neuromuscular scoliosis because many of those children are not going to be able to cooperate with traditional lung function testing. And so you're looking at alternative methods of lung function testing. Are you going to intubate and put all of them under anesthesia with a pneumatic compressor device to simulate a forced vital capacity? This is only done in a few research centers. We don't do that here, for instance. Are you going to repeatedly get 4D CT scans, which are much higher radiation doses than a traditional CT scan, even to measure the changes in their ventilation in their lungs over time? These are all very difficult things to do, and so not routinely done clinically. So the answer for number 3 is reduces vital capacity by about 40% perioperatively. And which of the following preoperative indices would predict difficulty in extubation following scoliosis repair? I apologize. I think I had a slide on this that I neglected to transfer over. So this is my fault. But in retrospective studies, what had been found is that failure to extubation was significantly associated with children with very poor forced vital capacities, less than 40% predicted prior to the surgery, or maximal expiratory pressure less than 30 centimeters of water. So this is a measurement of respiratory muscle strength. How high can they generate a pressure at their mouth by trying as hard as they can to compress all of their respiratory muscles? So if that pressure is 30 centimeters of water or less, those children after scoliosis repair, much less likely to be able to get extubated. Probably because it's a surrogate of overall respiratory muscle strength. Should I have shared the results?
You don't have. Oh,
I did it. And then for number 4, I didn't.
What other people have though.
For number 4, I didn't say why maximal inspiratory pressure greater than 30 centimeters of water. This would imply preserved muscle strength or fairly good muscle strength. So it's not associated with failure to extubate.
Perfect. Well, we did do fairly well on that one, I have to say.
Yes.
So just a few questions in the chat, and everyone feel free to add more if any have come up. First one being if there was any shortening of the trachea and its musculature as well on one side, which could explain the deviation. Ooh, interesting question, yeah.
I assume you're talking about specifically my patient. He had, I brought this patient 4 or 5 times, but this was months ago. He had not so much of a shortened trachea. However, his right major bronchi was abnormal. It appeared to be short, and there was almost no bronchus intermedius. So the bronchus intermedius is the portion of the right mainstem bronchi that's after the division of the right upper lobe. So you go into the right mainstem, first branch, right upper lobe. After that, bronchus intermedius. His bronchus intermedius was very, very short, which meant that all of the right upper lobe, the right middle lobe, the right lower lobe branches were all very proximal to each other, which was abnormal. And I suspected was a result of decreased growth of the right lung due to the severity of his scoliosis. Yeah, good pickup.
Yeah, very interesting question. And then from the same physician question of whether any of the children played a wind instrument at any point in their childhood. That is also actually honestly a very good question. I don't know if you know the answer to that one though.
There's only a couple of there was one patient I talked about. This child was not cognitively able to play a musical instrument. The primary study that I presented was in the young children who had scoliosis repair. So, the average age at the time of their scoliosis repair was 4.8 years of age. So I do not suspect many of them were, classical tuba players or anything like that. For an adolescent with scoliosis, I would hypothesize that playing a wind instrument would be beneficial for their lung function, but I would be guessing. I do not have facts to back that up.
Really interesting questions. I actually also had one clarifying one. When you were looking at the results of the studies, as much as we have them, you had mentioned the kyphosis worsening. Is that kind of a typical complication to expect, and how does that in turn then impact lung function potentially?
Yeah, great question. Yeah, they're typically going to go hand in hand, because once you get you start to get the vertebrae abnormally positioned and growing, you increase the rotational forces and the AP change in angle over time. So very commonly you're going to see kyphoscoliosis. The kyphosis has a much less significant impact on lung function unless you're getting negative kyphosis. So if the patients are hyperextended, it affects their lung growth. But exaggerated anterior kyphosis hasn't been shown to be that significant of a contributor to lung function.
Yeah, that makes sense. Picturing it like that, I was like, oh, I feel like I could have potentially figured that one out for myself now that I have the mental image back. And I'm so glad you went over the kind of anatomy and physiology pathophys again as well, because I do feel that that really answers a lot of our questions on these kiddos.
Yeah, I think my primary goals were to discuss, this is a very complicated 3D structure. You're looking at changes from normal in every direction potentially, and that with scoliosis repair, you're not actually improving the patient's lung function. As far as lung function, really what I'm interested in is you're halting further lung function decline. So, patient's going to have preserved lung function till a Cobb angle of about 60. It starts to drop. How far are you going to let it drop before you intervene? Okay. And then immediately after the surgery, it's going to drop further, but then it will improve over months to years, and you get back to where you are, maybe 2% higher, but you've locked in their lung function decline there. You're not going to get significant improvement afterwards. So if a child's desaturating at night because of their scoliosis and decreased alveolarization, decreased vital capacity, you fix their scoliosis, you're going to have problems as they recover from the scoliosis. Maybe rather than oxygen dependent, they're positive pressure dependent for a while. But then once they're the healing completes, they're going to go back to being oxygen dependent, most likely.
Thank you so much. Thank you for answering all the questions, and also for that really wonderful summarization one more time of the take-home points. Oh, one last question came up as I was about to release everyone into their afternoon, which was if there wasn't a drop in the lung function perioperatively, would it then improve? So I think meaning if we don't have this, up to 40% drop.
So my impression of the reason for a lack of improvement in lung function after scoliosis repair is because primarily of the issues with the respiratory musculature and compliance of the chest wall. Okay, so if you have a flexible vertebrae that is abnormal because it's bent, and then you have fixed it, but the way you fix it is with staples on one side or the other, or a rod going through it, a posterior spinal fusion where you've fused multiple vertebrae together so that they're locked in place. That's still going to be a poorly compliant chest wall. And as that patient grows in size, it's going to hinder vertebral growth in a lengthening of the vertebrae as well. The muscular changes are often fibrotic. It's not just these muscles are atrophied from poor use, they've become fibrotic. So you don't get the muscle strength back either. And so I have no data to answer this question, but I wouldn't have high hopes. I think that the issues with the lung function decline are not actually because of the curve, but because of the changes in the musculature and the chest wall compliance, which doesn't improve significantly.
Thank you so much. Thank you for
Particularly
answering.
Particularly with the diaphragm, right? So you may not, my patient, for instance, that I presented, his diaphragmatic function is likely not to improve. And so it's going to continue to cause ventilation issues on that right lung.
Absolutely. I know these very, very complex kids, obviously, that end up staying in the hospital for longer, much better than I know the ones who do well and are extubated and on room air and going home. So I've seen the more complex side of things. Good to know that there are also patients that don't require quite as much support from us. And that really seemed to do well after the surgery as well. I'm seeing some thank yous in the chat. I hope I didn't miss anyone's questions, but I do also want to be mindful of everyone's time, and it is now officially after 1 o'clock. So I will say thank you so much again, Dr. Beaty. We really appreciate having you here for any of the talks you've given. This one, as always, has been very interesting. And I think very worthwhile for all of us to learn more about. So thank you everyone for joining. We will be back on, I believe it is July 5th, unbelievably already, for our next topic. Summer, can you help me out? Do you have the schedule in front of you?
July 5th, Dr. Morgan, visual diagnosis of child abuse. So
wonderful, a very happy topic following 4th of July. In the meantime, I wish everyone a good rest of the month, a good start into the next academic year. Don't forget the new interns start on July 1st, and everyone have a wonderful 4th of July long weekend. We will see you then. Thank you so much.
Thank you.
Thanks, Dr. Beaty. Hello.